It's 2 o'clock. Shall we wait just a minute to allow people to join? Grab a drink if you are on the call already and you just want to get a glass of water or a coffee. And I think we'll start. We've got 11 people at the moment. We'll start in a minute or two. Okay, it's 2:02. We haven't had anyone else join, so as I say that. Good afternoon, everybody. We're going to go through the agenda, but first, in terms of housekeeping, we will be recording part of this session, which will be focused on Upcourage and veteran health. There's then a thank you, Karen. Then there is some time to discuss the future direction of the network. So by way of introduction, I'm Olivia Fodrack-Jones. I'm Deputy Director of Clinical Delivery for Mental Health. I'm chairing today instead of Tracy, I think, who probably had another commitment, but we'll come to that point under that section 3 around, or section 2, future direction of the network. So if we get started with Adele on Upcourage, if that's okay with you, Adele, and then we'll take questions, comments, and open up the discussion.
Yeah, okay, thank you. So thanks for having me here to speak today. I am not sure how many people will have heard of our service. So there is an Upcourage service which covers the entirety of England. It's provided by different people across the patch, and we do the direct provision of Upcourage on parts of this southeast patch. So it's for Buckinghamshire, Oxfordshire, Berkshire, Hampshire and the Isle of Wight. We work very closely with Sussex NHS Partnership, and I can provide their details and referral pathways later, and I think Karen will also be linking up with their lead, and they cover the rest of the southeast patch. So we're kind of being commissioned across an old geography that everyone else, I think, has moved away from, and we are starting the process of recommissioning, and we're expecting that it will map onto this 7-region model, so that will just tie things together like this a bit more neatly, I think. But yes, that's kind of just thinking, you know, who's on your patch in terms of Upcourage. So we're an NHS service, and yeah, this is something that hopefully people may have heard of these other bits. So we were actually rebranded as Upcourage fairly recently. And what happened before that was there were 3 services which were sequentially commissioned. So the first was the TILS service. Then we had this complex treatment service, or CTS, and then much more recently, here's the high intensity service. Then they've all been integrated and put under this one banner. So sometimes people have heard of one of those services, but not Upcourage. So I guess the headline about us is we're here to provide a bespoke and specialist service for veterans. So any ex-British military, you only have to have served a day in the forces to be able to access our service, plus you need a suspected mental health problem or diagnosed mental health problem. So hopefully that's a good message to people here, that actually, you know, there may be people sitting on people's caseloads or colleagues' caseloads that we may be able to offer much needed help and support with. So I'll just kind of go through what we do directly and then just think about the kind of bigger picture and maybe how things can tie up, and we can be a bit more collaborative, hopefully, going forwards. So what we do is people entering the service will be offered a holistic assessment, and then if needed they'll have case management, so that may be warm referrals. They're allocated a peer support worker that could follow them throughout the entirety of their time in our service. A family worker we're recruiting at the moment, who again would support them through that entire journey and pathway, but they'll be able to access it from as soon as they enter into our service. Then if needed, if people have military attributable mental health problems, then they can receive up to 32 sessions of psychological therapy in our service. That'd be one-to-one sessions. So we treat things, majority of our caseloads, things like complex PTSD, PTSD to, you know, combat and other things, could be bullying, actually, things like that have happened in the military. It's definitely not all combat focused by a long way. We also can work with veterans where existing services, so IAPT and other secondary care services, have tried to intervene, but it just hasn't been successful. So they need kind of further input and work to address their problems. And it's likely in some of those cases that maybe the problem isn't what it seems to be. So it may be that people have something like a moral injury, which is often a shame-based problem, and they just don't feel able for various reasons. Could be Official Secrets Act, or could just be the shame itself to talk to people about that, their therapist about that. And that's something that our service has, for example, a specific intervention and pathway for, and ways of trying to help people open up and talk about that. So it may just take that they need a bit more military specialist knowledge, or just having, you know, the branding of being a veteran service in itself can be helpful for some people as well. So other things that we do, as well as those one-to-one therapies, we've got an anger group. We have a group called Be Your Best Ally, which is a compassion focused group. We also have psychoeducational and stabilization groups, including one that's targeted at helping people develop a kind of meaningful civilian identity. So it's targeted at the transition from the military. So people don't have to have just gone through that transition, but it's where people haven't made that transition successfully, and there may be psychological factors that are holding them back. So they may be overly wedded to a military identity. They may have found it very hard to find meaningful and purposeful things to do within their kind of civilian role and civilian community. So that group targets things like that. So I guess broad brush, what we do is that specific stuff we would not expect other NHS services to do, where you really need to bring that military specific lens and know about military culture and how that would interact with the mental health. But we also do this other bit where we want to skill up the existing provision to be able to do what they do day in, day out, but with veterans, so that when a clinician or support worker or social prescriber sits in the room with a veteran, they don't feel fazed by that fact, that they feel that they're equipped to do their job with that person. So we do, one thing we do is we have an Armed Forces Champion, an Upcourage Armed Forces Champion network. The aim of that is every organisation across our patch would have at least one Armed Forces Champion sitting within their organisation who champions the needs and awareness of the Armed Forces community and thinks about how that organisation can work with those people and engage them. So there's a training that's available on that, and then we actively maintain that network through offering CPD events, newsletters, updates on policy and service provision and all that kind of stuff. We also provide training at request. So things like Thames Valley Police Custody got in touch and said, can you do a training package for a whole load of new custody staff they had coming in? So if anyone's interested in anything like that, we're open to doing that and able to do that. The next thing that is something we've been trying to do since we've kind of got our services much more bedded in and set up is more the systems level work. So it's more thinking about how do we promote this veteran awareness at a broader level? How do we start thinking about trauma-informed care for veterans? And I really acknowledge, like, veterans are going to be a minority on people's caseloads. And that is the challenge. That's why we work in this way, because actually they're everywhere. So it's kind of, you have to have a bit of a link across the board. So, you know, substance misuse, housing, IAPT, kind of into the MOD services, the charities. So this is kind of our model for trying to do that. So I do acknowledge it may just be a very few people who come through, but it's about us, you knowing that we're here to support you, your staff, to meet the needs of those veterans the best that that we can. So that's kind of, I guess, a bit of an overview of our service. Is there anything else? I guess the HIS part of the service, so that's much more veterans who have, it's not crisis because they would still need to be under a crisis team, but it's urgent care needs. So really it's thinking where a veteran is, maybe people that your service is coming into contact with actually, but where something's destabilized them, they were in treatment, they're no longer able to engage, there's been a rapid deterioration in their situation, things are starting to go wrong, relationships, work, housing problems, and there's kind of a wraparound care with family support, and the aim is to restabilize that veteran so that they can re-engage in the more mainstream support and treatment. That may be within our service, it may be within the local provision. Okay, so I think that's kind of, people can ask questions, but that's kind of the main overview of what we do. And this is just some quotes really from our service users. I think the main message is what we often hear back from organisations, particularly military charities, is they want to know we do a good job in order to feel assured that they can refer veterans to us. And I just wanted to kind of flag up the feedback that we get, and we're very open to people contacting our service. So if you have a problem with someone getting referred through, just pick up the phone and we'll see what we can do to resolve that. So yeah, moving on. So veteran picture. Now, I guess what are the things to say about veterans and homelessness? So I guess overall they're not overrepresented. So there isn't an excess of homeless veterans compared to the general population. That's what the data is overall showing. Now you can find studies and different things that like government organisations have done, and the stats do vary a bit, but that is the general consensus. I think, and there's some things I think to bear in mind. So housing issues would only manifest once the people are transitioning from the armed forces. Before that point, since 2017, they haven't had to take up MOD accommodation. So about almost 50% of armed forces personnel already own their own houses, have mortgages whilst they're serving in the military. So it's only in that transitional period that housing becomes a problem. And again, the stats are showing it's a problem for about 12% of people transitioning. So again, the majority are fine. I think the thing to say about that 12% is there was one study that flagged up that I think about 11% of veterans who are homeless, they have those multiple exclusion issues and problems. So they're a really high need group. And I think that is the main message that I'd want to send is we're not saying there's loads of veterans out there, that veterans are homeless, that there's actually lots of tailored support. There's financial schemes in place. There's, you know, the RAF provide informational advice services on transition and things like that. So there's work being done. The evaluation of that work, you know, something that people are working on improving, and improving the, you know, the detail we have about this picture. But it's really, I think, about those high need people. So, you know, the armed forces, to be blunt, recruit people from, you know, deprived backgrounds in effect. So you have potentially these issues of childhood adversity, trauma, then that can both be worsened in the military if people are exposed to trauma in combat, but people are also insulated whilst they're serving. So even with housing, you know, housing will be provided, MOD housing. And they can psychologically be insulated in other ways with all the support and structures that are in place. So it's then on the transition that those needs can become a bit more apparent and people start to struggle. So I think what I wanted to kind of say today is I'd be really, really interested to hear from you guys either on the call or afterwards about what patterns are you seeing in veterans? What are the struggles when you're trying to engage veterans, or the problems they're presenting with? What are the struggles when staff are trying to get those veterans linked into community services and NHS services? And just think that through, because it's probably this joining up of criminal justice, substance misuse, homelessness, all the socioeconomic problems, as well as the mental health. And that would be a really positive thing to kind of approach that from a collaborative point of view, and see if we can get some kind of pathways and thinking in place that just really supports those high need veterans. Okay, so on to the next slide. Yeah, so this was I mean, that's just to say, I guess there are lots of different things that are being done, but there is support out there, both financially, people trying to evaluate these things. And I think overall at the moment there's a lot of goodwill and things happening and funding being put into things, but the picture is still a bit grey because studies tend to be quite small scale. A lot of it's qualitative, so we just don't have a really detailed breakdown of the kind of picture, I guess, for veterans and housing. But we have some good kind of ideas which I've outlined of what's going on. Okay, next slide. Yeah, so I've kind of touched on this, but these are the main risk factors for veterans becoming homeless. And so you've got your kind of dual diagnosis stuff, your income related factors, and childhood adversity. And I guess these are probably all linked and or can all be linked in lots of cases, but also there's kind of a military bit that feeds into that. So obviously you've got the military culture around drinking and alcohol being something that's encouraged and very much part of military life. You've got transitional issues which can feed into income related factors where people are leaving the military and, you know, finding new housing, new jobs, relocating to new areas, losing support networks, things like that. And then I've touched on the childhood adversity, but obviously that can feed into these other things. And I think if you really approach this stuff from a trauma-informed lens, then it starts to make a lot of sense. And I think that's one thing I was hoping for anyone who is keen to kind of put out there today is, you know, if we could get something together like a collaborative workshop, joining different providers together and really think about what would a thought through joined up pathway look like for this group of veterans. So yeah, just to think about the risk. So I think here this was actually proportional. So it's comparing veterans who are homeless to veterans who aren't homeless, and it's saying that they're almost 8 times more likely to commit suicide than veterans who aren't homeless. When they did the same comparison for civilians, homeless and not homeless, it came out slightly higher. But what it is saying is that, you know, if you've got a veteran who's homeless, statistically, there could be a much higher risk of suicide there compared to the non-homeless group of veterans. So yeah, looking forward, I've touched on this stuff already today. So yeah, it's about collaboration and joined up pathways. To kind of give an example of that, we established this criminal justice system, and we've invited, it's still in fairly early stages, but we've invited multiple different providers, and we've really identified kind of parts of the system where we can do things differently. And a lot of it is actually just about joining dots. So it's things like something called out of custody disposals. So putting our service there as a treatment option, making sure it's appropriate, that there's an appropriate treatment option there for veterans, that they're not sent to something that they will never attend for psychological reasons or military specific reasons, and therefore it's kind of doomed to fail. So that's one thing, for example, we've put in place. Or another thing that came up through that was the exit from prison. So that's again kind of a risk time for people lapsing into kind of different difficulties and reoffending, and just making sure what we're setting up is this departure lounge, so that veterans are leaving prison are identified in a timely way, and you've got the professionals together, and there's a warm transfer out of the out of prison with the support there, rather than that gap. So that's an example of just where getting the right people together in a room can make a real difference, and it's actually not any more work for anyone because it's actually just joining dots together. So yes, and I think, you know, coming here, it's kind of you guys are the experts obviously on homelessness and the people that you're working with, and because we're a kind of service that we're plugging into that stuff, so we are not replicating and replacing existing provision. We're trying to get veterans to where they need to be, and we do direct provision where that wouldn't be delivered within your standard services. It's really about kind of working together so that we can build on the expertise that exists in these areas and just apply that to the veteran population. Okay, so this is just kind of an overview at different parts of the country, what the different Upcourage who the different Upcourage providers are and how you'd access them. And on the next slide, yeah, this is who. So as I said, mental health problems suspected or diagnosed, as long as they've served at least 1 day and they just need to be resident in England. And for our patch, it would be in Buckinghamshire, Berkshire, Oxford, Hampshire or Isle of Wight. And then I will make sure Karen's got the details to circulate for the rest of the South East patch. And I think I've got, yeah, then how you refer. So who can refer is kind of everyone and anyone. Family members can refer, self-referrals. So we've really tried to kind of break down the barriers as much as we can. And then the next slide would just, says how to refer. So you can download a referral form or just call or email the referral form to that address. And like I say, if there's any questions around referrals, just do pick up the phone or email that. That's a team email account and we'll respond to that. Okay, so that's me done. So yeah, any questions or responses? I'd be really interested to hear what people's kind of thoughts are, or difficult, like I say, difficult cases you've worked with, or equally being positive kind of areas of, you know, where things have gone really well and what's helped that.
So we've got the first question from Nick. Thank you, Adele.
Thanks, Adele. That was a really useful, really helpful presentation. I've spoken to a contact who works with homeless groups in Oxfordshire, and she said that one of the issues with homeless veterans was they tended to form very compact social networks to support each other rather than seeking outside intervention, and that when you actually came across veterans, they were usually well into a deep crisis. How do you think we could possibly identify people at risk of reaching crisis and break down the stigma against a military background where you carry your own weight? Thanks.
Yeah, I mean, it's a tricky one, isn't it? And I think it's kind of thinking what we can reasonably do, because probably there's every part of the system needs to come together to help that, right from when people are actually in service. And, you know, housing used to be allocated according to rank and marital status, and that they changed that as part of the review they did and said actually it should be allocated according to need. So you have these issues which can't be divorced of, you know, that come up, I guess, socioeconomic issues right from when they're serving, and, you know, all the stigma attached to mental health, struggling, the military culture. You know, it's a big question, I think, in lots of ways. But I think on a practical level, you are right. I think this pattern of people will try and cope and won't reach out for help until they're in a total crisis is one that we see, and people then deteriorate. So I guess first thing, it's going to sound very simple, but is asking if people have ever served. So as soon as people are coming into the service, just identifying that. There can be all kinds of barriers, like if you say veteran even, I know I've said it loads of times in this presentation, but people don't even identify they might have served in the armed forces. They think, oh no, you had to be in World War II to be a veteran. So, you know, just asking that question, have you served, or anyone in your family served, as that kind of first line, you just know who you're dealing with. In terms of the the engagement. I mean, what we have found hugely valuable is having lived experience within our service. So we've got some really fantastic peer support workers, and we've done everything we can to expand that within our service. So I don't think I'm not saying it's necessary and you have to have been, be a veteran to engage a veteran, but it's really helped. And the way I think we could share that with other providers is through training. So they will go out and do training around kind of awareness, language, all the informal stuff that, other people who aren't veterans probably won't say, and they can give a real kind of, just realistic angle, I think, on that stuff. So how might people present? How might they cover up? Why might they do that? So yeah, that would be something. Okay, is that answered your question enough? Like I said, it's a really big question, but yeah.
Yeah, no, thank you very much. And I'm afraid Olivia's had to leave, so I think the baton's been passed.
Okay.
Paul, your question, please.
Yeah, thank you, Nicholas Adele. Thank you so much for that presentation. Really, really helpful. I work for BHT Sussex, so we have services in Brighton and Hove, West Sussex, and going into East Sussex as well. And I currently oversee floating support contract. But prior to that, working as a senior manager in complex needs, high support accommodation. So yeah, just really to give you some reflections of what we've seen over the years. I think one of the difficulties is quite often clients come to our services having been rough sleeping, and actually to determine whether or not they have been in the armed forces sometimes can be tricky, because it is a coping strategy on the street to remain safe. Yes. So actually establishing whether or not they'd served, it can be quite difficult to begin with, and trying to unpick that with a client. I think substance use is certainly something that we see that's very, very prevalent, but quite often alcohol use is certainly there, but also in terms of other substance use, solvent use, perhaps those substances that are not illicit, might be the go-to for some of our clients. So we saw that, and then also during or pre-legislation to ban legal highs. Legal highs were also very, very popular within that community, because they were viewed as being legal and therefore safe. And then I guess the other bit that I'm really pondering, and actually it's been fantastic to be here today because it does seem like there is an answer to it, is where clients really do fall between the net of substance use services and community mental health support. And quite often it's the chicken and the egg scenario, where you need to be managing your substance use to get mental health support and vice versa, when actually, and I think we have a much better understanding of this now, it's the trauma that is making somebody behave in a particular way rather than out of choice. So I think it's quite complex. I think that there's an incredibly interesting group, and you're right, I think that they are a minority, but actually the work is incredibly complex. So thank you very much for your time today, and certainly we'll be in touch to see whether or not we can link up with you guys to provide extra additional support to our ex-servicemen within our services.
Brilliant. Yeah, I think actually there's a whole piece of work going on in Hampshire and Isle of Wight around the dual diagnosis stuff, which I've actually linked into that. And I think our service is, really what, if we could get something like a collaborative workshop where we had kind of the homelessness issues represented, the substance misuse, both charity provision, the NHS providers and us. I know it's for this veteran group, but that is what we're looking at currently doing, actually, and just saying kind of how could we support things better, because we do have that remit to work with people who have substance misuse problems. So we can kind of provide a bit of that bridging. So we wouldn't be doing, residential treatments and things like that, but we can do a bit of the bridging and probably coming at it from that trauma angle, where we assess and formulate and understand it through that lens. So if people are ultimately, these are our fallout, it's the fallout of trauma and adversity, and things like that, you know, so effectively it's a coping issue. You can't ask someone to get rid of their ways of coping and then say, oh, and then we'll address all of the other stuff. So it is a bit of thinking, how do we join up the pathways between those specialist substance misuse providers and us and other providers, admittedly just for veterans, but you know, it's a starting point.
I've just raised in the chat whether there is an appetite from members on the call today about pursuing the suggestion made about a workshop, because if there is, then we can look at arranging that. Pop it in the chat box and I'll take a view. Thank you.
Brilliant.
Thanks, Karen. Jason, I think your hand went up first and then Nick, if that's okay.
Thanks very much. Adele, that was great. That was really interesting to hear. And you mentioned kind of the normalization of alcohol use, which is kind of really worrying. But often, sometimes that can go along with kind of gambling as well. I wonder whether gambling, something you see much of in the service?
Yeah, so again, a lot of these problems, I think really we probably don't know the reality of these, how problematic or how the rates of these things, because they're probably underreported, because there can be a lot of shame around those kinds of problems. So again, from a trauma lens, you would see that in that kind of you know, it really sits within that threat system problem, really. So yeah, we would think about that as that's something we will definitely be incorporating into, you know, if we thought about it more as addictions, would have the substance misuse, alcohol misuse, and things like the high risk taking behavior, gambling in there as well. So in a way, you can see that stuff as an attempt to manage a kind of out of control threat system, I guess, if you're coming from a trauma perspective. So yes, it is something we'd want to approach and think about together. You're right for flagging that.
Yeah, interesting. Thank you.
Need to not forget it.
Thanks. Nick, you have your hand up.
Just to agree, I think great to see some of those understandings coming through. I won't wax lyrical again about the kind of the functional relationship between mental health issues, obviously, and drug and alcohol issues. Totally that coping, the understanding that ingesting a substance of some form is a way of coping with what might be diagnosed as PTSD. I think PTSD's got quite a nice, is fairly good, a fairly good construct validity in terms of attention to threat being cause of attention to threat. Where it gets really complicated, I think, and complex, as you said, is in the relationship between complex trauma. We know that childhood trauma and ACEs are overrepresented in the armed forces. And of course, why would you go into, if you're struggling with your family and, you know, that's one way out, but those problems, of course, never go away. And then, of course, there could be re-traumatization in armed conflict, or also, you know, I need to tell you, there's some really interesting data from Andrew Wesley comparing the US and the UK patterns of tours of duty, stuff like that is kind of interesting, which seems to indicate the US have got way more problems, particularly in terms of PTSD, seems to be associated with the length of tours and the number of tours done, and seeing active service, obviously. Where maybe perhaps we are is exactly right. It's the interplay between the adverse child experiences, learning to cope in particular ways, and having maybe a culture where ingesting substances is not uncommon, going into the armed services and still having those ways of coping. It might be eradicated for the time in which they're in the armed forces, but then it exists as a way of coping again when they come out, particularly if either those complex trauma issues are still going and or if there are other traumas that have been faced within the armed services, or whether, you know, or even the kind of, you know, the shame of dishonourable discharge or whatever. So some of the people I've treated, not many. I think we had, the other thought I had, sorry, just rather than disagreeing with everything you said, is for people who we were taking off the streets, we had about a 20% rate. It was a small sample, but a 20% rate of people who had been in the armed forces. And I wonder whether when you start to section, when you start to stratify, you know, according to, I don't know, people who have stayed out longer, perhaps, who may be more avoidantly attached, therefore self-reliant, and therefore might not engage in services. We might find differential rates of prevalence rates for people who have been in the armed forces. Just those are some of the things I was thinking about.
Yeah.
Building to a workshop, of course, would be really interesting, and thinking about the way in which we provide services, the special needs of people, of veterans, and the need for and the effectiveness of veteran mentors, which seems to be one of the key things, and maybe sort of exploring those mental health, substance misuse, or ways of coping kind of issues within a kind of a big forum might be really interesting.
Good, thanks, Nick. That's really helpful, and it's making me think as well. You will, like you say, there will be at-risk groups as well. So if you think childhood diversity, early service leavers, but untrained early service leavers, as in unsuitable for service, then they're a much higher risk group, and so it is. Yeah, there's not a homogenous group. Then obviously everyone always sends a message. The majority of people in the armed forces have successful transitions and go on to have very successful careers and lives, and when we know that, but that's true as well for, I guess, general population, isn't it? And we're just concerned with the people struggling. So I think, yeah, that would be, I'm sure a lot of this stuff obviously applies to civilian population, doesn't it, as well, for the same groups, but it just gives a focused forum to start that thinking in a way.
Sorry, one thing that comes to that, I wonder if actually we have an endemic problem of this separation of drug and alcohol and mental health services. Oh, just stop drinking drugs and your mental health problems will go away. I hear it way too commonly. And I wonder whether actually pragmatically, starting with a defined population and the effective work that can be done there might then signpost for other general services.
Yeah, exactly.
So starting Rockpool, effectively your Rockpool, and maybe we generalise on that understanding.
Yeah, exactly. Because under the theoretically, in principle level, it's the same stuff. There is some military specific stuff, but really there's a lot of stuff which is just about being human, and trauma, really. So yeah, that would be, that's the vision.
Thank you.